Good afternoon, everyone. Welcome to the webinar of the Geriatric Emergency Department Collaborative. We're happy to see you all here. My name is Don Mulady. I'm an emergency physician in Toronto, Canada at Mount Sinai Hospital, and I'm one of the faculty members with the JEDC. Today, we're continuing in our series of webinars on core topics in how to create a geriatric emergency department. And today, we're doing something slightly different. In early March, our world was rocked by a major event, which was not a cure for COVID, but rather the publication of a very important paper that was one of the first to carefully assess the impact of some of the components of a good geriatric care, and not just on patient-related outcomes, but rather in terms of financial impact. Now, it's always nice, these webinars, because we're preaching to the converted, and so everybody on this call knows that geriatric ED care is good patient care and it's good for patients. But sometimes one of the biggest stumbling blocks to implementing that good geriatric ED care is convincing those other people that it is not costly, financially intrusive, and therefore not feasible. For today's webinar, we've assembled an expert panel consisting of the lead author of the paper I just mentioned, a second guest with a system-wide perspective who co-wrote a commentary on it, and our prize captive unicorn, somebody very special, a C-suite executive who's also a long-standing proponent of geriatric ED care. There aren't all that many of them around, and we're glad to have one with us today. We hope you'll be able to go away from today's webinar with some practical tips on how you can change your hospital's leadership attitudes about the financial benefit of geriatric ED care. We've got a diverse audience on the call today. We're already at nearly 80 people. There's clinicians and administrators from emergency departments and healthcare systems from across the US and around the world. And then our three excellent panelists as well. The Geriatric ED Collaborative, next slide please, is a network of community and academic emergency departments working together to define best practices in what geriatric ED care is. Our goal is to educate ED clinicians, doctors, nurses, and others about models of care that improve care of older people. We support emergency departments and health systems to implement those models of care, and we research and evaluate outcomes. If you share the vision that you see on the screen today at the moment, your ED can join us currently for free. We are putting the link for membership into the chat box. International members are welcome, of course. You can check out jedcollaborative.com to learn more, and you can follow us on Twitter at the JEDC. Next slide. The JEDC is generously supported by our friends at the John A. Hartford Foundation and the Gary and Mary West Foundation. We really appreciate their support, and it allows us to keep doing the work that we love doing. Today's webinar is being recorded, and a link to the recording and the slides will be available on the website soon, tomorrow or the next day. As we go along, if you have specific questions for one of the panelists, please text it in and I'll try to see that it's addressed. As we get started, no previous slide for the moment, as we get started, can I ask to hear from some of you? So please enter into the chat box where you're calling in from and what your role is there. And before you, when you select the chat box, you'll notice there's a little blue drop-down menu. Please select panelists and attendees so that everyone can see. So next slide at this point. The two articles that we'll be considering today are here. on the screen. There's both the research paper and the commentary that goes with it. They're available for download, free, open access, and that'll appear in the chat box as well. We have three panelists with us today. Our first panelist is Dr. Ula Hwang, a professor of emergency medicine at Yale University. She's the co-lead of the Geriatric ED Collaborative and the lead author on the JAMA paper. The second presenter is Dr. Kevin Biese, who's the Vice Chair of Academic Affairs of Emergency Medicine at the University of North Carolina. He's the other co-lead of the Geriatric ED Collaborative. And around here, we generally refer to them as mom and dad. Along with Maura Kennedy and Kei Ouchi, he wrote a provocative commentary on the JAMA paper, so we'll be exploring that. And finally, our third panelist is Dr. Scott Wilber. Scott is currently the Chief Medical Officer for the Mount Carmel East Hospital in Columbus, Ohio. So he's the guy who sits in the corner suite, who has the big ideas and has to manage the big budget that makes it happen. So we're very, very interested in his perspective, all the more so that for the last 20 years, Scott has also been one of the early adopters of geriatric emergency medicine and has been a major researcher, practitioner, and advocate in the field. He's been a colleague and mentor to many of us. It's wonderful to have Scott back in the fold. Next slide, please. So before we get started, we would like to poll you and your thoughts about this. So I know you think a lot about clinical outcomes, but when you think of the financial benefit of a geriatric emergency department, in your opinion, what is the main financial benefit? And I don't know if the poll is open. Your options are improved reputation for your hospital and therefore increased market share. Is the main financial benefit coming from decreased hospital admissions, from decreased length of stay in the emergency department and therefore decreased resource use, from decreased return visits to the emergency department, or from improved staff efficiency by offloading complex care to people who are better at providing that care? So I'm going to give you a moment to make your selection. We'll hold off on the answer for just a moment, because next I'd like you to go back to the chat box and answer this question. What might, at your site, when you think of your emergency department, what are the arguments against making geriatric emergency department changes? So what kind of things do you hear about the reasons that you can't do the things that you want to do? I'm going to give us 30 seconds to address that question. Okay, thanks. So now our poll has just come up. So interestingly, there's a more or less even spread. The least impactful, according to our audience, is improved staff efficiency by offloading complex care. And the strongest argument is decreased return visits. So I think our panelists are likely going to be addressing most of those. Connor, maybe you can text those results into the chat box as well. So before I turn the show over to Ula, I think, are we going to go to full screen at this point? Great. So our panelists and guests are visible to us. So I'm going to start this off with Ula. with your team at various sites, you performed this study and produced this paper with its somewhat, I think many people found startling and heartening results. So I'd just like you to tell our audience about what they can expect to see in that paper when they read it.
Great. No, thank you, Don. So for those of you who have seen the paper, this will be a review. And for those of you who haven't, I'm going to give you the mini version. Don wisely said, pretend you're talking to your mother or your grandmother and trying to explain this study to them. And so the mini version of it is basically we took a look at over 25,000 patients. They happen to be Medicare beneficiaries, and I can explain a little bit later why. These are 25,000 patients who had an ED visit at some point at one of our JediWise sites. So JediWise was a program that was funded by CMS to really implement geriatric ED care. These patients had to have come through our ED at some point over a 3.5-year period, and on their first visit into one of our EDs, if they were seen by a geriatric ED nurse or social worker or, so they could have been seen by either or both, we compared those patients and their total healthcare costs the month after that ED visit to all patients that were similar to them over that same period that were never seen or touched by them. And what we found is that the patients that were seen or touched by the geriatric ED nurse or social worker compared to those not touched had a savings of almost $3,000 in the first month after that ED visit. So we, in essence, sort of changed their healthcare and medical care cost totals and change that trajectory to savings. Some of you might be wondering, well, what exactly did your geri ED nurses or social workers do? And we found that there were probably about 10 common things that they did. For the most part, they were screening for risks for falls, mobility limitations, cognitive impairment, being on multiple medications or high-risk medications. And then if patients were found to have some of these risks, then they might get additional evaluation by a pharmacist or a physical therapist. They had needs that were filled, so care coordination out of the emergency department, maybe to going to rehab or skilled nursing facilities, even something as basic as transportation back home. So for the most part, and there were like a series of about 10 or so interventions that were commonly done across our 2 EDs. You might ask, well, why did you do this study? The reason we did this study, and I want to emphasize, it wasn't a trial where we were like randomizing patients to being seen or not being seen. This was just, real world implementation of this process. So it was using observational data, but using the same data previously, we had demonstrated patients seen by our geri nurse or social worker, we could decrease their risk of being hospitalized and, decrease their risk of having a readmission if they were recently discharged from the hospital. And you might say, well, that's interesting, but like maybe they just came back and we're seeing it like in the emergency department multiple times afterwards, or they just went to more outpatient visits, or maybe they went to a different ED. And so we wanted to take a look at total costs of care. And that's why we did this study. And you can do that with Medicare patients because for our cohort, we were able to we actually had access to all their Medicare claims data. So that means like we had their costs for inpatient stays, all their office visits, if they even had like a walker, so durable medical equipment, if they were seen in hospice or skilled nursing facilities, we had all of their costs. And that's how we were able to summarize all of this.
And how do you know that how did you establish the comparison group? Like, how do you know that those people were different from some other, from the average older patient going to the emergency department?
So great question. So this is where you're probably saying like, well, I'm sure your geri nurses or social workers cherry pick these patients and like, stayed away from everybody else. And there's that potential for selection bias. And so that's where the study techniques that we used here allowed us to, of the 25,000 patients over this 3-year period, about 10% of them were seen by the nurse or social worker, and no, sorry, 17% were seen by nurse or social worker when you combine them together. And the remaining portion You're absolutely right. We don't know if they were different or not. And so we used a technique called entropy balance, which allowed us to weight characteristics by making the groups comparable. So it was basically patients seen by the social worker or geriatric nurse versus everyone else weighted to look similar to that same group who were never seen by this team over that 3-year period. And so we're sort of comparing apples to Macintoshes, so similar to similar groups, and then able to then look at the total costs over the first month, and actually even up to 2 months after, we still saw that they had consistent savings, total savings.
And how durable and prolonged do you think this impact is? I know you didn't study this, but $3,000 in the first month, does that continue month after month forever, or any theories about that or opportunities to study it?
Yeah, so we didn't expect, we looked at, so in the first month, it was about 3,000 saved at both hospitals. At 2 months for one hospital, it continued to be at 3,000 or a little higher. And for the other hospital, it went down to in the 1,000 range. And I do think that it does wane. You can't say it's forever, because one ED visit doesn't change, you save you thousands and thousands of dollars for the rest of your life. But what I do think is happening is it's changing their care trajectories. And for some hospitals, those care trajectories stayed and persisted.
And last question from me, there'll be ample opportunity for others. But so I know this wasn't the purpose of the study, or do you have any theories or hypotheses about where that saving came from? $3,000 is a lot of money in a month.
Yeah, I think $3,000 per patient is a lot of money. I think most of the savings probably came from an avoidable hospitalization. I think, as we know, inpatient, for older adults, we actually, it's better for the patients if we can to safely discharge them. They have many risks and often adverse outcomes when they get admitted to the hospital, and hospitalizations are expensive. So if there's an opportunity to provide similar care to the patients on an outpatient setting, in the outpatient setting, that actually can be cost savings. And so my hypothesis is that most of the savings came from avoidable hospitalizations. And it sort of makes sense with the previous analyses that we've done with the same cohort, whereby if you're touched by at least the transitional care nurse, we know that they are able to reduce your risk of being admitted.
Okay, so Edison, thanks, Ula. There'll be opportunities to direct questions to you as well, but I want to move on to Kevin. Kevin, you wrote a provocative and insightful commentary along with Maura Kennedy and Kei Ouchi to this article, so you know it quite well. But just moving it into the real world, you and I both know lots of emergency departments around North America that employ geriatric nurses and social workers. Many of them have two, and I just did and while $3,000 is a lot of money, it doesn't, in my pocket, it might not mean much to a corporation. But here's a simple calculation. If there are 2 full-time geriatric ED nurses at a site, and they each see 6 patients a day, and they each work 5 days a week, that's 60 patients, older patients, they're seeing a week. They each work 50 weeks of the year, that's 3,000 patients a year. If Eula's study is correct at a cost saving per patient of up to $3,000, you can do the math that this study suggests they're saving the healthcare system $9 million per year. So that's a lot of money. Do you think that's actually true? And what do you think the impact of that is?
I think GEM nurses should demand a raise, I think is the natural conclusion from your assessment there.
I hope our GEM nurses are not on this webinar. I know that they are.
A substantial raise. I mean, even if you only give them, say, 10% of the money they're saving. No, so maybe is my answer to your question. Consideration 1, I would echo Eula's statement that the cost savings are highly likely from avoided hospitalizations. Some of the other great work she's done has shown up to a 16.5% decreased chance of being admitted. In the United States in 2016, per HCUP data, the average admission cost was over $11,000, or charge really was over $11,000 per admission. And it's probably higher in Medicare beneficiaries, but who knows? Some of these complicated Medicare beneficiaries may even be higher. So if you can avoid an $11,000 hit, even if you have to provide some outpatient services, there's a good chance of cost savings. I think it's highly likely that the cost savings we're seeing are from avoided admissions. So to answer your question, if those two nurses can decrease substantially across all the patients they see the likelihood of medically unhelpful admissions, then yes, they are highly likely to save the healthcare system lots and lots of money. But important proviso here, which healthcare system are they saving money for? When we say they're saving money for the healthcare system, what we really mean in this case is for the payer, is for, in this case, Medicare. That's different than when I go to Scott and say, hey, Scott, man, you should pay for this intervention. You should hire these GEM nurses, because I'm not necessarily saving that money for Scott. I might be saving some of it, but what Eula's incredibly important paper shows, and I am so grateful this is out there. I think it's hugely important. It makes a very strong argument that these interventions that are better for patients are also better for the healthcare system at large. It'll make it more sustainable. And in a country where we're spending down our Medicare trust fund quickly and have very difficult decisions to make, saving money at the same time you improve care is a very good thing. But her paper is saying we save money for Medicare. And what we need to do with those findings as clinician champions that want to be able to support this kind of work in our hospitals is figure out how to translate that into a sustainable ROI or initiative, make it possible for our hospital to pay its bills doing this work. Saving money for Medicare may not be good for our hospital, but you might be saving Medicare $9 million in that philosophy, Don, or the National Healthcare System of Canada.
Well, we won't explore that in great depth, the National Healthcare System of Canada, but since we do have a number of people on the webinar from outside the United States, and I'm on the JEDC to represent the rest of the world, where most healthcare systems of the world are in fact single payer, sometimes with some other participants as well. But the large healthcare systems of the world, France, the UK, National Health Service, Australia, et cetera, Asia, Hong Kong, Singapore, they're all single payer systems. So where the impact of this finding of saving the healthcare system money has even more impact than it might in the United States. Ula, any comments about that? I know that you don't fully agree with Kevin's perspective on whether this is only a system-specific benefit.
Yeah. Yeah, I would say that the system benefits the most overall, but I want to also just make sure that people don't come away from the paper saying like, oh, well, we just saved Medicare money, but we just lost money. I think the way to think about it is we happen to focus on Medicare patients for this study because we were able to, we had all of their costs. Like we knew if someone, this Medicare beneficiary, if they came into our ED and then they went to another hospital and spent money there, Medicare dollars, you could look at the total cost for that individual. But I think the impact that our Jerry nurses or social workers are having, it could also be the same impact for patients who don't have insurance, right? If you think of it that way, there are a lot of patients who come in through the hospital that the hospital is now basically eating the costs of that patient and the care. Well, if we've just saved $3,000 in like projected cost for that individual, that's money that the hospital has back. So think of it in terms of like, yes, we might have like lost some money because Medicare saved money, but we may have also saved money on all the other types of insured or uninsured patients that have the same type of impact. So I think as a whole, I'd rather think of it as, well, we've just saved $3,000 per patient. Is this a way of thinking about this is what the ED can be reimbursed for providing this kind of care? So for every Jerry ED nurse or social worker that sees a patient and does this kind of care, can the ED instead be, get some compensation for the fact that we just saved money for the whole health system? And that's a nice way to think about the payment.
Kevin, is that is that within the American healthcare system, which I don't understand, I don't think most Americans do either, but is that actually a realistic possibility that it might change the way remuneration happens?
Don, is there an American healthcare system? I mean, it's quite a discordant system if it is one. You know, absolutely, with a proviso. I think it is fantastic that we have good evidence that these interventions save money. I think the likelihood that we will increase fee-for-service reimbursement for specific services delivered within the United States is relatively low. And that's because that goes in front of a group called MedPAC, and there's some haggling over where that fee-for-service pie comes from, and it gets convoluted. But I think what you do, I think if I got to go convince Scott and I got to go to my CMO or my CFO or my CEO, and I want to say, listen, we can do this thing that's great for patients. And we have good evidence that it's saving resource expenditure. As I share that, what I want to know is, what are our C-suite's strategic priorities? What are they looking to accomplish? Because, you know, it goes back to the index you put at the beginning of this webinar. You had like equal answers for each of those. And that's exactly right, because the cost savings of a geriatric ED and what it's impacting is varied depending on what perspective you're looking at it from. So what you want to do is get a really good sense, is do something antithetical to my nature, which is listen to my C-suite and hear what their priorities are. Are they looking to not admit as many people? This can help with that. Are they looking to let the community know that this is a really important initiative for older adults and to bring older adults into their hospital and possibly admit them? This could help with that. And do they have contracts with Medicare Advantage, or do they have an ACO set up where they can capture some of those savings for their own revenue? So this is good news. We can use this information to help us get the support we need to take better care of patients. But in order to translate it into action in the United States, first you got to listen to your C-suite, understand the strategic priorities of the hospital, and then work together to implement.
And as it happens, we have a representative of all the healthcare executives in the United States and around the world in the person of Scott Wilber. So Scott, speaking for all of those people, what's your perspective on this? And specifically the paper that Ula produced, but also the bigger issues that go along with it.
First, let me compliment Ula. I think it's a great paper. I have no doubt that this does save someone $3,000 per patient. She, did great matching and a great study that showed that. I think that Kevin brings up a lot of good points, and I think to understand where the savings accrue, I think you have to understand a bit about the U.S. healthcare system, and I won't pretend to be an expert in any other healthcare systems. As someone mentioned in the chat box, there are a few ways that this could benefit a hospital. One is many healthcare systems currently are in what are called risk-based contracts, which means that they are taking on some of the risk for taking care of a population of patients. That could be in the form of shared savings, meaning if we spend less money for our group population of patients, we get to have some of that money given back to us. There are other things such as per member per month payments, where you get paid a fixed amount of money to take care of patients. And if you spend less, you get to keep more of that money. So I think that in those situations, this would directly benefit the hospital. And I think it would be easier to convince the hospital that, that this is an investment that's worthwhile. Of course, the hospital may take the cost on, but another portion of the healthcare system get the benefit. And so you're going to need to bring those people to the table. So in my hospital, if population health and our Medicare Advantage plan is the group that saves the money, but it's my cost center that spends the money, we're going to have to come to the table and come up with an agreement that this is good for the health system as a whole. And you may think, just like the US healthcare system doesn't all work together, healthcare systems don't always work together. And so that may be a challenge for some hospitals. I think that one other thing is to understand how hospitals get paid for inpatients, since one of the big benefits is not admitting as many patients. You may think that admitting a Medicare patient is financially lucrative for your hospital, but generally it probably is not financially lucrative for your hospital. Hospitals get paid a fixed amount of money to take care of a inpatient and a observation patient for the last few years. And if the patient stays longer than they should, or we order too many tests, we're going to lose money on that patient. And in Medicare patients, generally that payment is insufficient to cover the cost of the patient's hospitalization, especially if they're a medical patient. So a patient with pneumonia or angina that doesn't get an intervention, doesn't get a procedure, we're likely to get paid less money than it costs us to care for that patient. In that situation, you have something called an opportunity cost, where keeping patients that have low-paying DRGs out of the hospital by arranging better care as an outpatient gives you the opportunity to fill that bed with somebody who has, that really needs the inpatient care. And so that opportunity cost in a busy tertiary care referral hospital may be that we can accept more transfers from the outside that are going to need cardiac procedures or other surgical procedures, because it's the cardiac procedures and the surgical procedures that likely are paying for all the rest of the care that we deliver.
Thanks. So there's a lot of stuff to think about there. What would be your advice to someone wanting to use this paper to launch a convincing argument of a hospital executive?
So first, you're going to have to look at, to use this paper in particular, first you're going to have to look at and understand where the benefit, the financial benefit would be, since we're talking about financial issues in this paper. So where would the financial benefit accrue in your hospital system? Is it that we have a very large volume of patients that are in our own Medicare Advantage plan, and we really want to focus on that Medicare Advantage plan and keeping them healthy and out of the hospital? Do we have other at-risk contracts? Do we have an ACO that would be really interested in reducing cost and keeping those patients out of the hospital? Do we know that we're turning down transfers from other hospitals because we're full all the time? And if we could just open up another 10 or 20 beds in the hospital, we could fill those with patients that other hospitals are looking to transfer to us. So understanding where the financial benefit would accrue in your health system is really important. The challenge is that oftentimes the people that are very interested in doing this may not be at the table where we're discussing those things. And so you're going to have to partner with your CMO, with your CNO, with your population health team and say, well, what matters to you before you make your pitch? If you just go in and say, look, I'm going to save you money by reducing cost, and all your patients are, that benefit accrues completely to the payer, it's going to be a hard argument to make.
Scott, if I can, Don, I'm going to jump in there and echo that comment. It's complicated. It's complicated even for Scott, if I can say that. And for the rest of us, it's extraordinarily complicated to think about how the hospital finances work. And we can lay out a little bit more about what the value proposition of this work might be. But I think that last comment you just made, Scott, is for me one of the keepers, which is, listen, if I'm a clinical champion, I'm a nurse, a doctor, a pharmacist, I work in the ED, and I'm like, gosh darn it, I want to do a better job by my older adults. And I think the geriatric ED is the way to go. What I want to do is I want to walk in with a bunch of information, put it at the feet of a trusted ally, and have that person, have my Scott Wilber, help me figure out what that means in our hospital setting. So what we can say today, because of Ula's great paper here and other papers, are things like geriatric EDs cut down on admissions, geriatric EDs cut down on costs. Those two things are not surprising given that they're probably highly connected. Geriatric EDs increase patient satisfaction. That's not her paper. And some other findings. There's some suggestions it decreases 30-day readmissions, or paper suggesting 30-day revisits to the ED. I can put that information at Scott Wilber's hands and say, hey man, I think this is really good for our patients. And Scott wants to do good for our patients too. And together we can figure out how that information works or doesn't work within our hospital, right? As opposed to most of us trying to figure out really the financial manipulations of how this goes through. What we're giving our colleagues across the world is additional information to share with their system and say, I don't know exactly how this plays here, but if it's good for the patients and it's saving somebody money, can we figure out how to make this work here?
So it takes more than just having a good idea. Like, let's put on a play. Let's provide better care for older people. You need to the advocates in the emergency department need to go the next step and gather the information, do the data sourcing, and make the argument as well. There are a couple of interesting questions pouring in. Let's go to one of them. Tess Hogan has a question specifically for Scott. Do you think that there's actually money being lost on the care of complex older patients? Or is it simply that the charges are not covered?
So the answer there is that charges are never covered because they have no relationship to cost in the US. There was a Newsweek article last week that somebody posted on Twitter their bill, and they were very upset that they were billed $450,000 for neurosurgery, and that they didn't post their bill. They posted their explanation of benefits on Twitter. $450,000 in charges, for which the insurance provider had negotiated a payment of $49,000 and the patient owed $650,000. And everybody talked about how horrible that was. But of course, the real payment to the hospital was less than $50,000. So charges and costs, there's not really a relationship there. But the costs are not covered by Medicare patients. Not my current system, but a prior healthcare system that I worked for. One of our biggest discussions in all of our strategic planning meetings was how we could make a margin on Medicare patients. And what that means is that usually your margin, or the percent of money for every dollar you get paid, the percent that you are able to save out of that is still there after costs. And a good functioning hospital in the US might only make 3 cents on every dollar. So 3 cents can be reinvested back into the hospital, because 97 cents goes to pay the lights and the people that work there and everything else. The margin on Medicare patients is usually negative. So you lose money on every Medicare patient that comes in. That doesn't necessarily play out across every diagnosis. So if you come in and you go if you're a Medicare patient and you go on ECMO for a short amount of time, and then you come off ECMO and we can discharge you quickly, we're going to make a lot of money on that patient, because ECMO pays about $150,000 for that DRG. But pneumonia pays about $5,000, and the cost of a day in the hospital just about spends that. So that's the answer to that. My answer to that question.
Okay, thanks for all that. Let's. I've got a case that I want to present to you. Laura, can you go back to the? So your friend is the Senior Director of Acute Care Services, covering the ICU, ED, OR, and internal medicine in a large academic urban hospital, 140,000 ED visits a year, large city, the flagship of a system with some smaller hospitals. So the director of the fundraising foundation of this hospital tells the senior director that there's a donor who wants to donate a large amount of money, $500,000 each year, for each of the following 3 years in order to help old people. So what would you say is your advice to your Senior Director of Acute Care Services? What should she do? Eula, what is there in your paper that's going to be helpful for her?
Yeah, so what a cool opportunity. I hope we all have an opportunity like this to have a friendly person that wants to help old people. Should we be fortunate enough to have a donor that wants to help our older adults? I think the first thing, based on the paper that we have, is to either create a position or to take someone already in your ED and train them to do the processes that I described in, like sort of the 10 common things. So what that geriatric ED nurse or social worker, case manager, it doesn't have to be one type of person, but it is a position that does that type of work, really identifying and doing the assessments for the older patients in the ED and identifying where they have needs, and then addressing those needs. So staffing up for that position and hiring as many as you can with the 3 years of support you have. And then the second thing that I would also use that money for is data. So you asked the wrong person, but I'm always very interested in data. So data, like, who is this person seeing? Like all the patients that they're touching and all the patients that they're not touching. And then sort of capturing the information of, okay, when they were touched, what did they do for that person? Did they get a pharmacy consult? Did they change their medications? Did they end up going to rehab? Getting physical therapy? Did they go home, or were they admitted or discharged? So capturing all of that information so that you can then, over the 3 years of your support, demonstrate and see if you've had an impact. Because if you can demonstrate that you've had an impact, then you can go back to the hospital and say, look, for the $1.5 million we got, I just saved you, or this program just saved you, you multiply times X amount, $6 million. So continue, even though the funding is gone, continue to sustain this position and these processes, because they are of value to the hospital. So thinking ahead about how you're going to continue to make the case to deliver this type of good care.
Good, thanks. Kevin, what do you say? How can you construct an argument? You've already alluded to some of the strategies. What kind of an argument are you going to be able to make to your chief financial officer?
I think that they should probably donate this money to the Geriatric Emergency Department Collaborative. I think that would probably have the most impact on the most number of older adults. In the off chance that that's not what they want to do with this funding, my second answer to this question is that they should quite seriously call the Geriatric Emergency Department Collaborative. We're not going to take the money, but to strategize around what makes sense. In leading to my next one, walk over to your C-suite's office and ask them about their strategy for older adults. How are they looking to set this up? Because you really want to make sure that you use this funding to launch a program such as the one Ula described that is aligned with the strategy for caring for older adults that your healthcare system has. And then track the data, I know data coming out of my mouth, track the data that either shows or doesn't show that you're making the kind of difference to the patient, but also for the healthcare system that makes sense. So before you go develop your program, walk on over to the C-suite's office and be like, what's our strategy? Are we trying to increase our market? So it's really different. I'm going to give you some examples. Safety net hospitals, right? Scott, love Scott, but I don't know your hospital, but probably not a safety net hospital, because safety net hospitals actually want Medicare patients. It pays better than Medicaid. And what happens in safety net hospitals around the US is when somebody turns 65, they leave the safety net hospital behind. So they're looking to retain those patients. That's a different ROI than a full hospital that, as Scott already alluded to, my goodness, if you've got a full hospital, the last thing you want to do is have an ambiguous Medicare admission that doesn't need a big intervention, because you want to save that bed for someone else. In my simple head, that's the kind of scenario where if like your restaurant's full, you don't want to schlep like me there. You want the fancy CMO there that's going to buy the fancy wine. You don't want me like burger and fries dude there. And so you've got to, you really have to target your program to be aligned with your leadership's strategy. Absolutely for the good of the patients, but also in a way that uses this really generous but still seed money to launch something and track its impact that can stick around after those 3 years.
Good. So going to be over to you, Scott, in a second. I think Kevin and Ula got to this quite quickly. I mean, $500,000 a year is a lot of money, but it covers the cost of several new people that Ula was alluding to, and maybe a medical director and some new beds. But it's only for 3 years. It doesn't cover everything. So, Scott, what kind of an argument, what does make this appealing to a hospital executive? In what way can this initiative be seen as beneficial, and what kind of an argument do we need to make in order for you to see that?
when you look at budgets in hospitals, you can look at them divided into, very simply into operating budgets and capital budgets. And you could spend this money in either one of those. A capital budget is going to be things that are expensive and one time. So they're going to be things like building something new, renovating an area of your ED, buying a new machine. That's a capital expenditure. You put a lot of money in up front, and then there may be minor ongoing costs, but not anything that's large. The second part of it is your operating budget, and your operating budget is the biggest part of that is going to be labor expenses. And so when I hear this, the concern that I would have is that it's great to have a lot of extra staff for 3 years, but when that funding dries up, we need to absorb that into our operating budget. And where are we going to, if we're making 3 cents on every dollar and we just keep adding labor expenses, pretty soon that 3 cents is going to be 0 or negative. So that's what I would have a concern about. I would want to know that in 3 years, we've got a sustainability plan that makes this, a sustainable plan, probably revenue neutral, in that we've either repurposed some people. I think the best thing would be to say, we're going to train up these people, but then we're going to need less discharge planners in the ED. We're going to need less case management staff. We're going to use our social worker, 60% of our social workers' time is going to be spent on this, and 40% will be spent on the other things that the social worker currently addresses. If we want to have physical therapists have more presence in the ED, how do we just repurpose them through the hospital so that they can respond to the ED without adding a lot of extra physical therapists? So the concern that I would have is, what's the sustainability plan, especially if we're going to put this $500,000 every year into labor expenses. We need to know how we're going to sustain that. And, the last year has been tough for a lot of hospitals. There's been layoffs. We've gone through these kind of things before. My guess is currently in most hospitals, they have a fairly strict rule on adding new positions, that has to go through some type of vetting process, and that you may even need to show where you're going to provide a cost and expense reduction in order to have an expense addition. Just because we know that labor is a large part. Labor might be 40 to 60% of your overall budget for every year. And that's where, that's the place where generally we can either add or cut, and that can swing our finances really significantly.
Good. So that's some of the ways in which it's a challenging ask. In what ways are doing something to help old people? How can that be presented as a positive or a win or a sell for hospital leadership, for a board or the executive?
So in addition to the financial aspects that we talked about earlier with opportunity cost, I think that understanding what quality metrics your hospital cares about and focusing on how you're going to improve those quality metrics is really important. There's a few ways that you can kind of figure this out. One is that there are publicly reported quality metrics that all of us are accountable to. So anything that is in the CMS STAR rating program is a quality metric that someone probably is paying attention to at your hospital.
Can you just
Can
you just give a couple of examples for those of us who are familiar with that?
Yeah, readmissions, hospital-acquired infections, those would be a couple. Patient experience. So patient experience is 22% of that CMS STAR rating. There's other organizations that also provide quality ratings of hospitals. There's the IBM Watson Top 100 Hospitals. There's Leapfrog. And so understanding the metrics that make that up, and you can find it online, or you can go to your vice president of quality and say, I want to understand these metrics a little bit better. If you're in luck, your hospital has something called a balanced scorecard, which is a document in which we track metrics every month. And we might include metrics on there such as mortality, readmissions, length of stay, hospital-acquired infections, falls in the hospital. All of those things could be impacted by having better geriatric care at your hospital. Your C-suite administrators might even have a portion of their compensation tied to their performance on those, and likely they do. Likely that there's a significant percentage of their compensation is at risk, not based on how many dollars did you save. That might be a small part of it, but what was your readmission rate? What was your length of stay? Were you able to improve your length of stay? What was your hospital-acquired infections? So those are the things that I would try to tie your improvement to. Find out what's important, what quality metrics are important to your hospital. And another good place to look is if there's a strategic plan. If your strategic plan says in 5 years, we want to be a CMS 5-star hospital and a IBM Watson Top 100 hospital, the case that you make is how your geriatric ED, your JEDI nurses are going to improve all of the metrics that roll into that.
Good. That's very instructive. Certainly the last one that you mentioned was very relevant at our site. As I mentioned before, 8 years ago, largely through the leadership of our geriatrics program, the board of directors at our hospital made being a center of excellence for geriatric care a strategic priority for the whole hospital. So after that, many of the things that we were pitching suddenly found much more receptive ears because everybody was being told, this is what our hospital wants to do. Kevin, any further comments?
I got a question for you, Scott. One of the analogies, those as you are in the geriatric ED world, what tossed around a lot is to pediatric emergency departments. And in the non-financial lingo, they're often referred to as loss leaders. Like you don't make a lot of money on your pediatric ED, but the whole community knows you're awesome because you have one. So if you bring Johnny there when he sprains his ankle, you bring his dad there when he needs a cardiac catheterization. Does the loss leader argument stick for geriatric EDs? Does that make sense to you?
I think it does in some ways. I mean, you definitely want to, you want your hospital to be considered a high quality hospital where people get a great patient experience as well as great care. And I think the geriatric ED oftentimes achieves both of those. And that does allow you to attract those patients and their families for other things at the hospital, like an outpatient surgery, which is something that's very important for us to keep our outpatient surgery suites filled. So I think that does make a good argument. I think that the reputation that you can have in the care of the geriatric patient is important. There are other payers for older patients as well. It's not just Medicare. And so some of and Ula discussed this, she can only study Medicare, but there's some people that are retired and still have their Aetna retirement plan. There are people that are on Med Advantage plans that pay better. And so certainly the reputation argument, I think, is a good one.
Thanks. As we start swinging towards the top of the hour, I'd just like to give you all a chance to tell our audience what you want them to take away from today's talk. Ula?
Yeah, so thank you. I think the main points I want to make sure people walk away from with this discussion are, with this paper, if you have to boil it down to the mini, easy version, it was a big study that really compared patients who were touched versus not touched by geriatric trained, emergency trained nurses or social workers. For those that were touched versus a comparison group that was made to be very similar, that were not touched, we saved about $3,000 in the subsequent months per person. So I think that, you can take that and expound it if you'd like. And I think that, these are numbers that we can now actually say like the dollar value of saved, because, before I was thinking, well, yeah, we just kept them from being hospitalized, but did they end up doing something else? Well, now you can look at the big picture and that in general, how much was saved. And I would love for this to be used to think about potential ways of reimbursing for this type of care in the future.
Good. Kevin, next slide, please.
Appreciate you advancing the slides so I remember what my main messages were. The cheat sheets are great. I'm actually going to sneak one in here before. It is fantastic that this paper demonstrates cost savings overall to the system. Better care and saving money at the same time is incredibly important. So having said that, how can I use that information to get better care at my shop, to create a geriatric ED at my shop? One, listen to your boss or your colleague. I don't really like thinking of the C-suite as my boss. As a doc, I just don't like thinking of it that way, but they are. But I want to listen to my colleagues in there. I want to listen to my colleagues on the business end of things and make sure that I understand their priorities. And then use that information to partner to take this important information Eula's paper shares with us to come up with a strategy that makes sense in our system. And then number 3 is really just an extension of number 2, but where your hospital has risk-based or value-based contracts, where they're on the hook for what is being spent on the patients they're responsible for, there is a natural alignment here. So I help run our ACO. I'm the vice chair of our ACO for UNC Healthcare System. And one of the first things we do with our geriatric ED is just go knock on the door of our leadership of our ACO and be like, look, this connects. We can save money and do better by our patients at the same time. And some of that savings will go straight to the hospital.
Good, thanks, Kevin. And finally, Scott, our captive unicorn, what do you have to say?
I think these are a little bit out of order from the way I presented them during this, but I think one takeaway is understanding the performance metrics that are important to the senior leaders at your health system. Look for a balanced scorecard or a strategic plan. And if you don't have those, focus on publicly reported metrics. Go to the CMS website. And I think Kevin put in there the big categories, but in each of those big categories, there are specific measurements that are part of that. Understand the finances related to the care of the geriatric patient at your institution. Who pays you, and do you have at-risk contracts, similar to what Kevin said? And then identify your ask and what you need to make your program successful. Are you asking for capital expenditures like building things, which is more money up front, but could be less money overall? Or are you asking for operational expenditures like paying staff, which is going to be a cost every year? And it's always hard to take things away once you've put them in place. And can you repurpose staff and move staff duties around instead of adding new FTEs or full-time equivalents to the books?
Good, thanks a lot. So Tess, were there any final burning questions coming out of the chat box, or just one that you wanted to highlight?
Hi. So it seems that the care of older adults will never match the reimbursement of, the high insurance payer organ transplant people. Yet we have to take care of older adults every day. So does Eula's paper help make the case that this is the way to optimize revenue?
I would say that I think it's a way of optimizing expenses, reducing expenses. The revenue is going to be what it is and is never going to equal, but you can optimize the expenses that you have for a system by, add a little expense here and save a big expense in a hospitalization.
Thank you. It's great.
Good. As we're wrapping up, I just want to point out that, as usual, our friends at West Health have provided a lot of valuable resources. If you want to summarize this, the high quality content of this hour webinar in just 2 pages, I'd urge you to access this brief toolkit, making your business case to the C-suite, as well as having sort of big thoughts in it. It provides a lot of really simple, concrete examples of what you can do to more successfully make your pitch. Next slide. Just a reiteration that please visit our website, follow us on Twitter, and stay connected with us. Next slide. We are generously supported by John A. Hartford Foundation West Health. We're now taking a little summer hiatus, which I hope all of us can enjoy. We will not have a webinar until the 3rd Monday of September, and then we'll be starting our fall season at that time. I'd like to say also a big thank you to our three special guests, Mom and Dad, and the unicorn. So Dr. Hwang, Dr. Biese, and Dr. Wilber, thanks so much. We've learned a lot from you, and we'll look forward to having all of our guests with us again.